Good afternoon and welcome to the OR Today webinar series. We're excited to have our 160 registered attendees for today's webinar. Just a reminder that our 4th annual OR Today Live Surgical Conference will be held August 26th to 28th in Nashville, Tennessee. Join us to discover new opportunities, broaden your knowledge and exchange ideas. If you register before June the 30th, you can save $50 by entering the promo code SUMMERSAVER. That's SUMMERSAVER. For more information, please visit ortodaylive.com. Okay, let's kick off today's webinar by giving an OR Today Live surprise pack to the attendees that can tell me the answer to the following trivia question. June is National Aquarium Month. Which state is home to the largest aquarium in the US? Answer now using the questions feature on your dashboard. While you are answering, I want to remind you today's webinar is eligible for 1 continuing education hour. To obtain your certificate, you must complete the post-webinar survey, which will appear immediately on your computer screen at the end of today's call. 1 lucky attendee will have the opportunity to win an Amazon gift card, courtesy of OR Today, just for completing the survey. Okay, let's see who the winner of our OR Today Live surprise pack is. It is Christy Warren. Congratulations, Christy. The correct answer is Georgia. OR Today would like to thank our sponsor, Tru-D. Tru-D SmartUVC is an advanced UVC disinfection system that delivers 1 automated measured dose of UVC to consistently disinfect an entire room from 1 position, ensuring significant pathogen reduction in direct and shadowed areas, eliminating human error and documenting disinfection results for each cycle. For more information, please visit tru-d.com. Our presenters today are Alice Brewer, Director of Clinical Affairs at Tru-D SmartUVC, and Tesha Broadfoot, Quality Leader at Phelps Memorial Health Center in Nebraska. Alice, you may begin whenever you are ready.
Okay, thank you, Linda. So good afternoon, everybody. Today we're going to talk a little bit about real-world disinfection success. I'm just going to give a brief overview on UV and why we even talk about it and why it becomes significant for the OR space. And then I'm going to turn it over to Tesha from Phelps Memorial Health Center, who has some experience and some success to share with you all. So just to let you know, I do work for Tru-D SmartUVC. I am an epidemiologist and an infection preventionist. I've worked in the hospital setting. I've worked in pharmaceutical surveillance, but I currently work for Tru-D, and so that's the perspective from which I'm speaking today. And then Tesha is the quality leader and nursing leader with Phelps Memorial Health Center, and you'll hear from her in just a few minutes. So I think as infection preventionists, certainly, and I think in the OR as well, we tend to live and breathe by our rates, and we're constantly looking at numbers on spreadsheets and graphs, and we see rates more often than we see individuals sometimes. And so I think it's always good to start these conversations off with talking about the people and the patients who were impacting by these infections that we sometimes inflict on them when they arrive to the hospital expecting to be made better, and they end up leaving sicker than when they arrived. About 2 million individuals in the US are infected annually with a hospital-acquired infection. You know, this can increase the length of stay. It adds to both the hospital's financial burden, it adds to the patient's financial burden, and as we're learning, regulatory agencies are no longer reimbursing for infections that are caused by the hospital. So it really becomes both a significant problem from a patient safety standpoint and also a financial standpoint. So we talk a lot in UV about disinfection and what spaces need to be disinfected and what surfaces need to be disinfected. And there's been a lot of historical research on high-touch surfaces and the idea that we really need to get those kind of high-risk surfaces and those ones that we touch most often, door handles and bed rails and sinks and toilets. But there's an emerging branch of research that's saying, it's actually a pretty strong branch of research saying that there really isn't any epidemiological evidence that one surface is more likely to transmit an infection versus another surface. You can sample a surface on the opposite side of the room from the bed and the bathroom, and then sample a surface, from the bed rail, and you'll find very similar levels of contamination. So essentially, we really need to disinfect every single surface in a room in an OR theater. There's not one area that we need to spend more time on versus another. Every surface is important. And so expanding that concept kind of to the OR space, there's some research out there showing that bacteria present in the operative suite can be one of the most important factors associated with surgical site infections. Now, we know a lot of times we talk about deep organ space versus superficial infections, and we won't go too much into that really today, but we do know that kind of that environmental contamination and anything that might be in the environment in an OR can contribute to surgical site infections, whether it's a surface that's being touched by a clinician and then, coming into the operating field, or it's something that's present in the room, maybe in the air. But especially those fomites and items and surfaces that are close to the surgical field are really critical to be disinfected because they can harbor a lot of bacteria. And then they serve as a reservoir essentially for wound contamination and SSI development. So I think it really just kind of heightens that importance of making sure that our OR spaces are really clean and that we're not leaving anything behind from a previous case or a previous day's surgeries. So why do we talk about UV? I'm actually going to skip ahead a slide. We'll come back to that one, but why do we talk about UV? So when we talk about the spectrum of light, I won't go too much into the physics of it, but light occurs at different wavelengths, and the UV wavelength is is a little bit shorter than visible light wavelength. And in particular, UVC wavelengths are much shorter, and that allows them to penetrate the cell walls of pathogens, and it disrupts their DNA. It creates dimers in the DNA, which essentially renders the pathogen unable to replicate, unable to cause infection. It doesn't kill it right away. Eventually, it will die because it can't replicate itself. But that shortened wavelength of UVC light is what we call germicidal. You get into UVA and UVB, slightly longer wavelengths. Those are what give us sunburns and what can make it through, the Earth's atmosphere. UVC essentially is blocked out by the Earth's atmosphere, which is why we're not concerned about it in our everyday lives. But when we can introduce it into an environment, it becomes a germicidal agent, and we can use it for disinfection purposes. So UVC efficacy, how do we know that it works? There have been a lot of research studies on this. This is one that I think has done a great job of demonstrating that log reduction ability of UVC. This was by Dr. Bill Rutala out of UNC back in 2010. And this has been replicated in other studies. But what he's showing here is that for these 4 organisms that he looked at, and in particular C. diff, because that tends to be what a lot of people are concerned about. But for these 4 organisms, the log reduction, the total log reduction is almost 3, just shy of 3. But in direct areas, so direct line of sight, so something that's directly in front of where the UV light is placed, oftentimes that's going to be the bed or the top of a bed table, you get an over a 4 log reduction. But the important thing, I think, about this is that in those indirect areas, so that's a shadowed area, so that's the underside of the bed table, the underside of the bed, maybe the back side of a piece of equipment in the OR, kind of those areas that aren't direct line of sight, that if you think of a shadowed area, so underneath something or behind something, you still get almost a 2.5 log reduction of C. diff and well over a 3 log reduction of some of these other bacteria. So the question of how do we know it's working, you know, I think this is a great demonstration of what kind of log reductions you can see when you're using UV. So specifically in the OR, because I know that's what everybody here is interested in, and that's what we're here to talk about. There have been a couple of studies recently looking at Tru-D in the OR. The first one was done in a series of ORs. They looked at both small and large, and what they were looking at specifically were those anesthesia workstations, which I think, coming from infection prevention, I had many conversations about who is going to clean those. And I've heard that repeated in many hospitals that I've been in, is, oh yeah, you know, is it EVS? Is it the OR staff? But essentially, it's tough to know sometimes whether or not those machines are really being cleaned as well as they should be. And there's lots of tubes and screens and buttons and things where bacteria can hide. So I think it's important to pay attention to those and make sure that they're getting clean. But what this study demonstrated was that they could see a 2 to 4 log reduction in bioburden, regardless of the size of the OR, regardless of the space that the UV was placed in. And so that was a great demonstration that adding UV to your OR terminal disinfection process can kind of eliminate those reservoirs and those hidden places where bacteria might be hanging out in the OR. And this study looked at some of the major pathogens that are responsible for SSIs. So I think it was important for them to, you know, look at it in a, you know, a real world setting, like not necessarily MRSA or VRE, but what are our patients being impacted by, and, you know, can we see a reduction in those pathogens? And then there was another study in the UK in the last 5 years where they looked at both direct line of sight and shadowed areas within an OR theater, and they again saw 2 to 4 log reductions for MRSA and VRE. So this was different pathogens, but essentially the same results. So on that note, I will turn our presentation over to Tesha Broadfoot from Phelps Memorial Health Center so that she can share their experience and successes with Tru-D.
Great, thank you, Alice. So as they said, I am Tesha Broadfoot. I here at Phelps Memorial am the quality leader, risk manager, and safety officer. So my goal is completely to focus on quality and safety for our patients and staff. I have been here at Phelps for over a year. My background is nursing. I was an RN and on a critical care floor in an acute care facility. And then I went to be a director on that floor, and about 1.5 years ago decided I needed to take a little bit different path with my life. And so I always loved quality and risk, and so I tell everybody I'm doing my dream job now. So I will tell you a little bit about Phelps, and then I'll go into why we chose Tru-D. Here at Phelps, we are a critical access hospital. We are known for our mission statement. I think it is something that we have done an amazing job of advertising, and it is our brand completely. But it is to provide exceptional quality and compassionate care for the families we serve. We, here at Phelps, we want to be the first choice for healthcare. We are in kind of the central southern part of the state. About 35 miles away from us is 2 acute care hospitals, and then about 60 miles away from us is another acute care facility, and then we're about 50 miles from the Kansas border. So you can see that we truly do serve the patients right in our community and area, and even though we are a critical access hospital, we want to provide that quality and exceptional care for our patients and families. So that's just a little bit about our vision statement. It is to be the first choice for healthcare. Next slide. Our values are the people who we provide the service for. Being in a community of 5,500, we want to take care of our own. It's our family, it's our neighbors, it's the community. It's the people we've grown up with. We want to be compassionate, quality, and have cost-effective care. And just as Alice said, we know surgical site infections is huge. It adds to that patient's recovery, potentially getting them more procedures in the future, more hospital stays, increase in medications, etc. So we do want to make sure that we are cost-effective for our community, because just as I said, we do have 2 acute care facilities only 35 miles away. We want them to choose to come to Phelps to have surgery here. Continuous learning and active communication. I will discuss in a minute how we have a very active board. They're integrated into our mission. They want that high quality of care. Just the other day, I heard a staff member tell somebody that here at Phelps, we are very spoiled because we do get to have the equipment some other facilities would not get. We want to be responsive to changing healthcare needs. And I'll show you in just a second how we provide, how many surgeries we provide in our community. We want to be effective stewardship of our healthcare resources. We want to collaborate in partnership with other providers in the delivery of healthcare services. We do have a number of physicians that do come to our area to provide care. And the one thing we love is you hear that every single time from them. This is a great place to come. We enjoy coming here. We know our patients will be well taken care of. The use of technology that enhances healthcare services, and we'll talk about that. And then an environment that is patient and family focused. So this slide just kind of shows you our service area. I talked a little bit about our location, where we are. Our primary service area is within about, if you would put a circle around our community, about 45 minutes around our community is our primary service area. Our secondary service area does go down into the Kansas area, and then it's spread out just a little bit more around our central part of Nebraska. Patient demographics. This shows you kind of the ages of patients we see here at Phelps. 42.5% of patients 65 or over, pretty common for most facilities. 35.1% of patients 40 to 64. We are lucky. We have a few physicians from Steamboat that come in to do our spine, knee, and hips. And so that I think helps kind of get that population. 15.3% of patients 18 to 39. We do deliver babies here at Phelps Memorial. And actually, I am proud to say last year we had 125 births here. And I think this year we are at 40, and we've had a couple sets of twins. So that kind of helps that generation. And then 7.1% of patients under 18. We do have a ENT that comes and does, he sees outpatients here and then does some surgeries here for ear, nose, and throat. And so he is able to provide that kind of population taken care of here. I've discussed a little bit about our service lines. We have inpatient and outpatient, acute care, primary care, orthopedics. We do the OB, and we do C-sections right here. We have a anesthesiologist that has that comes out from Colorado also. He's here about, I would say, 6 times a month, and he provides pain management in our same-day services for our patients. We have a full diagnostic imaging. We are very, very lucky to have the equipment we do right there in our imaging, and that helps with our surgical. We have diabetes education. We have a cardiac rehab service and cardiopulmonary service. Therapy services. We do have an emergency room that serves our community right here. And then we have community outreach and education. So a little bit about our on-staff providers. I've told you we have visiting providers that come do surgeries, but we do have 7 credentialed physicians. We are very proud to say that we have 3 family practice physicians that will be adding our staff in the fall time. We have 6 physician assistants, 4 advanced practice nurses. We will be adding podiatry the first of the fall. That'll be a service that we're very excited to offer in our community. And then we have 267 staff members. So you can see that we do serve our community well. Usually on an average daily basis, I would say we run a daily census of around 13 to 14 patients. And our ER usually sees about 300 patients a month. Our capacity here, as I said, it is a critical access hospital, so we have the 25 licensed beds. We have 4 specialty care beds, meaning they are the higher level. We monitor our patients in there, and they can be considered as an ICU. We do not keep vents longer than 24 hours. If they need it longer, we try to send them on to one of our nearby acute care facilities. We have 21 medical surgical rooms, and they're all private rooms. We have 3 OR suites. So we did do 1,100 cases last year, and I'll talk a little bit about that. And then, as I said, we do have a very active emergency department with 6 beds. So Tru-D, as Alice has just explained about it, we brought that in June of 2016. During that time, they had done some investigation. The leader that proposed that is not at this facility, but our guest services leader we have now is a very integrated part of keeping Tru-D active and moving it into our inpatient areas. We were probably one of the first facilities in central part of Nebraska to implement it. Crazy, in 2014, I was doing research trying to figure out how to handle C. diff, and I know this was kind of a innovative process then. And so when I first came to Phelps a year ago, when I'd be making rounds on the floor and back in surgery, I would always hear how this Tru-D was hard at work and she had 45 more minutes to clean this room. And I was so confused. I thought, I need to meet Tru-D. I thought she was an employee here because that's the way they talk about her. They act like she is one of the staff, which is awesome. But haw on me, once I figured out it was a machine, then I was even more interested in how it impacted our numbers and our infections. The infection control preventionist does report to me. She is all about what is the best at that time and what is new and ongoing. And so she has been very implemental with Tru-D in our facility. We first started in 2016 with the goal to use it in surgery. And when they initiated it, that was the whole plan, is that EVS would do their cleans, and then at the end of the OR day, they would go ahead, place Tru-D in the OR and do the deep clean. And then they would know the room was ready for the next day. So that was kind of the plan, was at the last scheduled case, they would utilize Tru-D in the room, and then they would go ahead and know the next day that that had been through the clean. When we implemented Tru-D, we did have the rep come out and do a lot of education. We are lucky that our EVS staff have been with us for numerous years. And so the couple individuals that do the majority of the cleaning and surgery were highly trained with Tru-D. And then there was a lot of monitoring afterwards to make sure that we were using it effectively. We know that we can have a lot of equipment that does wonderful things for us. However, unless we know we're using it right, it just does not work. So the staff they went through a training period with it, and then a competency was done to verify that they knew exactly how to use Tru-D properly. And then they go through a training twice a year to verify that they are using Tru-D to what it should be used. When our guest services leader, she oversees dietary and EVS, when she came on probably about a year and a half ago, she had seen that Tru-D was being used in surgery and thought, this is wonderful. This is a great thing. However, why are we not using it in the nursing areas and the ER areas? So she had spoke with our infection preventionist, and they both agreed we need to utilize this. We have purchased this machine to help us decrease infections and to verify that that clean is done. And so she did help get that out there. Now, the fun part was with that, it's kind of like when somebody receives a new car. These surgery EVS staff, they were so protective of Tru-D. They wanted, it was kind of like they did not want to share. They wanted to make sure it was always in the area, and they wanted to use surgery. So that was kind of fun, but they have moved that out into our nursing and ER use, and then we have all staff trained. And I'll show you in a minute, we can pull reports to see how much of the staff have used it in a month, and which is kind of gives our guest services leader an idea of the usage of the machine. We also try to use it in our whirlpool room. So anytime we have a patient that is in any sort of isolation in our ED or our med-surg rooms, we automatically use Tru-D in those rooms following their dismissal. We have a really nice instruction sheet on that. We have them go through that when they go through the training, and like I said, they do training twice a year. So here is an example of the Tru-D monthly report. And these are our staff members' names. You can probably see from there which ones actually work in OR. Those three that have the highest, Natalie, Mike, and Michael, they have been in our OR team for a while, and they do use Tru-D completely. This just gives us an idea of how many times we're using it, and it makes sure that we're using it when we need to be using it. The hard part is it does take 45 minutes, and I'll kind of talk through that process in a minute for the instructions. But to verify that we're giving that full time to the Tru-D to run. And so we run reports on that, and that is on their report card monthly. The Tru-D report for the isolation discharge, the 100% means that they let it run through the cycle. And that is one of the challenging things, I think, for any staff member is if you know you may need it somewhere else, that they may try to end it quickly, but we want to verify that they run it all the way through the cycle. So these reports are ran monthly and discussed at their departmental meetings. I actually try to attend their meetings quarterly to review it, see if they have any concerns with it, and discuss why we do look at that so they understand the quality. Next, you're going to see their report card. And we developed report cards in the past year on every single department, and it's based off their departmental goals. One thing I would like to point out, and the number isn't on here, to be completely transparent, in 2016, we had 3 surgical site infections. We had around 975 to 1,000 cases. In 2017, I told you that we had around 1,100 cases. Unfortunately, we did have 11 surgical site infections. And so we do place this number on our EVS report card, so they know where those are. When we did our thorough review of the surgical site infections, we went through a complete team, including myself, our guest services leader, our pharmacy leader, the surgical services leader and supervisor. And when we did that full dive, the one thing that we were proud to say is it was never a first case. So out of those 11 surgical site infections, we never seen that the first case was one of them that received it. So that told us that Tru-D was doing its job. It also gave us a great idea of where to move our attention to for those surgical site infections. And so it did help us kind of limit that. You can see from the report card as of April, and I can say May now, we have not had a surgical site infection here at Phelps. But as all of you know, it depends on the type of surgery, and a lot of times those can be counted for 90 days following the surgery. So we feel pretty confident to say January and February are okay, and we hope to continue at this pace. But we did a lot of work with our EVS team, our surgical team, to look at that and to make sure that we were using Tru-D properly in our surgical services to avoid any infections. Also on the report card, we monitor their hand hygiene. We look at their disinfection of high-touch areas, and then we do look at their Tru-D isolation discharge, verifying that they let the Tru-D go through all the cycles, and they verify it has been completed before they remove it from that room. So they do not get in a hurry and take it to another room quickly. And then we look at some of our service questions regarding cleanliness, and then we look at our 90-day turnover. We are very, very blessed to have a engaged EVS staff, and I think that does help our numbers completely with our surgical site infections and keeping people current on Tru-D. Our infection preventionist just had attended National APIC up in Minneapolis last week, and the first place she went was the Tru-D booth, but they were very engaged in getting us started as a critical care hospital on Tru-D. I would say one of the things that we've started seeing now that we've been using it for almost 2 years in our OR is on our machines just a little built up film. And so they are offering to come back out and do some education as we need to turn some of those away from that UVC light. And so those are some things that we will be educating our EVS staff on in their biannual education. And they bring those concerns forward to us with it. So that is one of the things that we will be using. I still think one of the areas that we would like to improve on is using it in our medical services rooms to verify that we are getting those deep cleans after patients leave. We are proud to say that we have not had a C. diff, and I keep knocking on wood in my office here as I speak. We have not had a C. diff in the past 18 months. So I feel like us using the Tru-D in our whirlpool room, our medical surgical rooms, and in our ORs helps with that. Those are some of the things that we have been trying to do. For anybody that has not seen Tru-D, it is a very fun thing to watch. We actually just had some students, high school students, that are in a program, and they get to come do some shadowing in our hospital. They spend a week in the summer performing that. They wanted to see Tru-D. We were not able to work that with their schedules. However, that is one of our goals for them to see that next year and allow them to understand what it is doing, because I think it is the wave of the future. It makes them understand how we want to promote cleanliness. As Alice said, it's hard to get behind all those areas. We're human, we make errors, and this helps just prevent that. When they prepare a room out on the floor, when they do the Tru-D, it does take out a room, so they do the initial clean. Once they follow that initial clean, they leave that bed unmade. We are lucky that all of our patient rooms have darkening shades. It's very important not to allow any light through when the Tru-D is running. They open the doors to the bathrooms. They open any of the drawers in the cabinets. And then they take the trash cans away from the wall. They try to take everything just a little bit away from the wall. They take Tru-D in there. They take off the sides, put it outside the room to notify there's a cleaning happening and that nobody enters it during that time. It's ran from an iPad. and then that allows our staff to know when it is cleaned. It could take some education with our inpatient nursing staff, as they felt like it almost had a burn smell. We joked and said because it was clean, but I think that is important, that you do need to educate how that room will look and appear following the cleaning. We do educate patients and families of what's happening. We make sure, Tru-D does talk to you. We make sure that the volume is down, so that way it does not bother any of our patients in a nearby radius when it is running. Does anyone have any questions? Or Alice, do you have anything to offer to that after I was done?
No, you have such a great story there at Phelps, Tesha, and I love talking to our hospitals that are our smaller critical access hospitals who don't always get the advantage of the high-tech devices and are sometimes a little bit behind when it comes to technology. So I love talking to critical access hospitals who have made it a priority to invest in the technology that makes their patients safer. And I like what you said too about you guys look at other things besides UV, and that's one thing that I like to promote as well. There's no silver bullet when it comes to preventing infections. I wish that there was. I would make all of our lives so much easier. But you really have to pay attention to so many things. UV is one piece of it. We know that the environment contributes to about 20% of infections. And then the rest of that comes from contamination of hands, from technique and procedure, from the other things going on in the hospital. So it's more than just using the UV disinfection technology. You also have to pay attention to hand hygiene, as you said, Tesha, and making sure that high touch surfaces are cleaned appropriately, that manual disinfection is being done well. So I always like to remind people that UV is very important, and I think it's great technology, but it's not the only thing that we need to pay attention to.
I agree, and that really did help us in our surgical site investigation. When you have exceptional quality and care right in your mission, and we were still below national average, but it was nothing we were used to. And so it did give us a good time to go back through and dive through every single case. And it really told us we were doing the right things, especially with cleaning, when we could see that not one of them was the first case. And that took us a little bit to even get to saying we need to look at which case of the day it was to identify the background on those surgical site infections. And so I want to be completely transparent about that. However, I think our interventions put in place will hopefully continue to show in 2018. We do have one surgeon here at Phelps, general surgeon. However, the rest of our surgeons, our ENT, our gynecology, the orthopedics, all of them come in from other facilities. And so we really want to be on that high technology side, have great outcomes, and be able to promote that. So they want to continue to come here and want to have maybe their partners come here too. So that is definitely one of the things. It helps keep our community members right here at Holdridge for their surgeries, or maybe 10 miles away from Holdridge, instead of having to go 30, 45 minutes or even an hour and a half away.
Okay, thank you very much, ladies. I have got a few questions here. I've got a couple that are directed at you, Tesha. One is, what factors did you consider when deciding to invest in UVC disinfection?
Thank you. That's a good question. I do have to be completely transparent on that. That was done prior to my time. However, the leader was very, she had went to some education on it and felt like that was the next step we needed to take here at Phelps. We wanted to be the best and not have those infections. Just as Alice and I said, though, there's many factors in place. But with us trying to build our surgical services here in our community, we felt like this was a great place to start with the Tru-D. As I said before, we have a very integrated board, and they do spoil us. And so it was a great presentation to them to show them why we needed it here at Phelps.
Okay, so have you seen a return on investment with the technology?
Absolutely, I would say we have. Like I said, I did a lot of research in my prior career on C. diff, and those things are sometimes hard to, I remember when I found the Tru-D back then on C. diff, how it was so implemental in C. diff patients because the cleaning of the room was important. And so I would say we have seen our investment, even if it is to show that our hospital-acquired infections are down, and it gives back to our patients and families in our community to verify they're going to have a surgery and hopefully not end up with a hospital-acquired infection.
Okay, that's great. I've got another question from attendee here. How many of the 3 SSIs from 2016 were recorded on the first case of the day?
I believe none of them were. When we looked back at the last 2 years, they were usually later in the day.
Okay. And did you say that some of the equipment in the OR appeared to be affected by the exposure to UV light?
It wasn't impacted. It didn't impact the equipment. The staff just started noticing a tiny film on it, and so they were wanting to verify it was still clean. And so with the film, they had some questions. We do, like I said, our EVS staff was very, very partial to their surgery, and they want to make sure everything's perfect in there. When they noticed the film, they just wanted to verify it was clean. And so with that, that's when they brought up the question, and we just know we need to turn a couple of those monitors away. We will not take them out of the OR. We'll just reposition them a little bit different. And it's probably because we've been using this for 2 years.
Okay, that's great. I've now actually got a question for Alice from attendee. With several players in the market, what makes Tru-D unique?
I think the biggest thing that makes Tru-D unique is that it can disinfect the room from one placement in the room. When we talk about training EVS and implementing this in a hospital, a big concern and question is the amount of time. Not only that it's going to take to disinfect the room, but also the amount of time that it's going to take EVS or OR staff to use the machine. And so when you look at a breakdown of how much time it takes to place Tru-D in the room and let it run its cycle versus having to come back into a room 2 to 4 times, depending on the size of the room, to move a UV device to a different position. That's really the big differentiating factor with Tru-D and the other devices on the market. You're guaranteed that you're getting the entire room with one position, whereas the other devices, you have to move it around a few times and you may still not be getting absolutely every corner of the room.
Okay, that is
Alice,
great.
I would like to add on to that. I would say the EVS staff feel like it's very easy to move and it's very easy to run. You know, the hard part is the time, but we know we need that time to make sure we get that thorough clean.
Okay, that is great. We don't appear to have any more questions, so we will wrap up now. So thank you for a great webinar, Tesha and Alice. It was very informative. Just a reminder that one lucky attendee will win an Amazon gift card for completing the post-webinar survey, which will appear on your screen shortly. We'd also like to thank Tru-D again for being our sponsor today. We appreciate that. For more information on our upcoming OR Today webinars, please visit our website, ortoday.com/webinars. Thank you once again, and we hope you enjoy the rest of your day and see you next time.